reminder for me to hit record there. All attendees will be muted, and we will do a question and answer session twice throughout the program. Once after Dr. Bagdasarian speaks, and once at the end. Please submit your questions in the chat box during the presentations. And if you would prefer to vocalize your questions, please use the raise your hand function during the question and answer component. Thank you. So as noted, we are fortunate to have a great lineup of speakers this afternoon. We have Nicholas Torney, who graduated from Ferris State University in 2014 and completed his residencies at Munson Medical Center in Traverse City, Michigan. He is currently a board-certified infectious diseases clinical pharmacist at Munson Medical Center and the chair of the Munson Healthcare Antimicrobial Stewardship Committee. Amanda Shelast. Ms. Shelast is a tenured healthcare executive with over a decade of expertise in rural healthcare, rural health clinics, physician relations, medical group operations, and critical access hospitals and Seoul Community Hospital operations. She serves as the Vice President of the National Association of Rural Health Clinics, as well as the Vice President of the Michigan Rural Health Clinic Network. Through these state and national roles, she advocates for the power of rural and the vital role rural health plays across our nation. In her professional career, Amanda serves as the Vice President of Physician Services and Clinical Networks at Marshfield Medical Center Dickinson. Dickinson is home to 7 provider-based rural health clinics in northern Michigan and Wisconsin. Dr. Natasha Bagdasarian was named the Chief Medical Executive for the state of Michigan in 2021. In this role, she provides overall medical guidance for the state of Michigan as a cabinet member of the governor. She's board certified by the American Board of Internal Medicine in both internal medicine and infectious diseases, and is a fellow of the Infectious Diseases Society of America. From 2020 to 2021, Dr. Bagdasarian served the state of Michigan in the role of senior public health physician, where she oversaw the COVID testing strategy for the state and helped bring rapid testing technology to vulnerable populations. Since early 2020, she served as a consultant and technical advisor for the World Health Organization, providing guidance on outbreak preparedness in COVID-19. She's worked in Michigan and internationally and has over 40 publications on topics in infectious disease and public health, including guidance on infection prevention and control of the SARS-CoV-2 virus, which causes COVID-19. She's held teaching appointments at the University of Michigan, Wayne State University, and the National University of Singapore. She's currently an adjunct clinical professor in epidemiology at the University of Michigan School of Public Health. And before I turn it over to Dr. Bagdasarian, I wanted to give a recognition to Teresa Jenkins, Region 1 Trauma Coordinator, also key personnel on the COVID-19 outpatient therapeutics team with MDHHS, who was the impetus for this webinar and the glue in pulling this webinar together. So with that, I will be happy to turn it over to Dr. Bagdasarian. Thank you very much.
Thank you so much. Thank you for the introduction, and I'm going to just share my screen. And for those of you attending this call, please feel free to turn your cameras on, and I'm happy to have a little bit of a discussion as well. This does not have to be formal. Okay, hopefully you can see my screen. I'm just going to go over really quickly where we are with COVID and what we're looking towards in the fall and why Test to Treat is so important right now. I'm starting with just our guiding principles because I think it's really good to level set. We are not trying to prevent every case of COVID-19. That is no longer a possibility. We're trying to prevent death and severe outcomes, protect healthcare capacity, and keep vital infrastructure open. And we can do these things because we have tools that we did not have at the beginning of the pandemic. Not only do we have vaccines available for everyone 6 months and up, but we've got over-the-counter tests that people can use at home, can use frequently to test anytime they have symptoms or have been exposed. We've got, of course, amazing therapeutics, and you're going to hear more about this test to treat model. And then, of course, we've got things like masks ventilation and distancing that we have had throughout the pandemic. What we're seeing when we look both around the world and across the country is COVID-19 is starting to spike again in a variety of places. We usually mirror what's happening in the United Kingdom for a variety of reasons, and they saw their resurgence with BA.5 not too long ago. What we're seeing across the US, so these are the CDC community risk levels, and we're really seeing things heat up in the South. Florida has been heating up for some time. And there's probably a couple of things going on. Number one, the BA.5 subvariant of Omicron is definitely the problem child here. This is causing a lot of this transmission, but also these warmer states in the South, a lot of folks are indoors in air conditioning over the summer. And I think we have escaped some of that transmission because we have great weather and people are socializing outdoors. So it's a matter of when we're going to see our BA.5 surge, not if. When we look across the state right now, we are starting to see counties at the high community risk level. And when we look at our RT, so whether cases are going to start going up or going down, the RT is higher than 1. So we are in a scenario where cases will probably start going up even more. And we have been calling this an undulating plateau. So we haven't seen a really sharp spike. Cases have just been sort of bouncing around this moderately elevated number of case rates. And of course, our case ascertainment is an underestimate because we know there are so many people taking tests at home. BA.5 is definitely predominant. So both BA.4 and BA.5 are transmitting at a higher rate right now across the world. And we are seeing BA.5 really emerge in this part of the world as well. When we look at what is expected in the fall and in the winter, we have always felt that there was going to be a COVID-19 surge when schools reopened. So there was always this forecast of a surge happening right around September and probably another surge happening in November, December. This is what we have seen the last couple of years, that when the weather gets really cold and people move indoors, there's sort of that secondary surge. And that's what the models continue to look like. Again, it's a matter of when, not if. So our cases might start going up before schools go back into session only because BA.5 is so much more transmissible and also more immune evasive, meaning that people who have prior immunity can still get BA.4 and BA.5. One of the trends that is very reassuring right now is our trend when we look at hospitalizations with COVID-19 versus COVID-19 patients in the ICU or on ventilators. This is slightly old data, but the trend is the same. The trend has not changed. Hospitalizations are up, but with previous surges when hospitalizations have been up, we also start seeing patients with COVID in the ICU and on ventilators, that's this yellow line and this blue line here, start to rise, and they have not risen. And this really speaks volumes to the fact that our vaccines are working and our therapeutics are working. So even though patients with COVID-19 are ending up in the hospital, they are not ending up in the ICU or on ventilators at the same proportion they had been before. When we have talked about COVID-19, we talk about this as a cycle. We talk about this as being a cycle that we're moving through at different times of the year. We have been in recovery ever since our last big Omicron surge, and we're getting ready. We are moving towards readiness in the near future because, of course, we are expecting cases to start going up. When we look at vaccines, we are underperforming compared to the rest of the country. So we are below the national averages when we look at vaccine uptake overall. Specifically, we've been having a harder time in our younger age groups. We've been having a hard time with those in the 20s, in their teens and younger. And of course, our vaccine uptake for the under 5 age group has been particularly low. And one of the struggles we're dealing with is not having vaccine appointments for them. We're also struggling when we look at vaccine uptake by race and ethnicity. And so African Americans across the state have lower vaccine uptake, but particularly in certain parts of the state. Sorry, I don't have the next slide on here, but when we look at specifically vaccine uptake by geography and race, what we see is that there are certain parts of the state where vaccine uptake is even lower. and Detroit is one of those areas. And whenever we look at areas where vaccine uptake is low, therapeutics become more important because we know that there are more people at higher risk for those severe outcomes. When we look at our COVID-19 therapeutics, we had relied on monoclonal antibodies very early on in the pandemic. And then, of course, there was a shifting of which monoclonal antibody was available during which surge and which subvariant. We're now relying most heavily on Paxlovid. And when we look at our rates over time, again, this is a little bit older data, but the data looks very similar to this, where our Paxlovid rates have been very high in terms of prescribing and uptake, and rates of everything else have been low. And we now have availability of Paxlovid. So availability is no longer the limiting factor that it had been initially in the pandemic, or initially when it was first approved under the EUA. And so the goal is to really get Paxlovid to folks at risk. So to those at risk of severe complications or severe outcomes. And the Test to Treat program has been a very useful way to get Paxlovid out there to folks who are at risk for those severe outcomes. And I won't go into the details of this because you're going to hear from some of your peers on what they're doing with Test to Treat in our state here. But I will just say that what we have been recommending overall for COVID-19 to the public is to have a COVID plan. So of course, number one, find out if you are due for a booster or if you have not been vaccinated. Of course, now is the time to do it. Keep a supply of well-fitting masks at home if you need to isolate or quarantine. Keep a supply of over-the-counter COVID tests at home. But we're also asking people to learn if they're eligible for therapeutics ahead of time, so that if they are eligible, if they are someone who is in a higher risk age group or with higher risk comorbidities, that they can right away go to a Test to Treat center and get prescribed a course of Paxlovid early in their course. So I will leave it there, just a general overview of where we are with COVID-19. I'm happy to take questions or have any discussion about the things I presented here today.
Well, thank you so much, Dr. Bagdasarian. It does look like we have one question in the chat box. And again, if you have a question, please feel free to put it in the chat box, or you can utilize the raise your hand function and I can call on you, or you can simply unmute yourself. So while folks are preparing their questions, we did have one in the chat just kind of asking for some guidance on why all the maps are different in their transmission levels.
Well, there are a few different types of maps. Maybe I'll go back to my slides so I can just show you.
Thank you.
Yeah. So I'll go back to my slides here and you can see the different maps that I typically show. So this is the CDC risk level map. So this is directly from the CDC website, country as a whole, and then looking at Michigan. And then we have some additional maps using the MySafeStart dashboard and using our MySafeStart levels. And this is the difference between those maps is really that the CDC maps combine case rates and hospitalization data. And that's really important because we know that under ascertainment of cases is a real thing. People are testing at home and they're not telling us that they're testing positive, and we don't have good insight into that data. So the CDC transmission maps are a little bit more helpful because they are combining case rates as well as hospitalization. And the MySafeStart maps are, it's an older way to look at the data because we're just looking at case rates. But it is sometimes helpful to look at just case rates and see if we're trending up or trending down. It becomes less helpful when we're looking at case rates this year compared to last year because there are more over-the-counter tests available this year. And when we look at cases overall, when we're looking at our data overall, what we are doing holistically at the state, when we're doing modeling, projections, anything, we're looking at a variety of different types of metrics. We're looking at case rates, because we have to, everything is sort of built upon that to some degree, but we're also looking at hospitalizations. We're looking at those ICU and ventilator numbers because that really makes a difference. Are people getting very sick or not very sick from COVID? We're looking at mortality data, and we're also looking at our wastewater surveillance data. And sometimes wastewater will give us an indication of what's coming in the next few weeks and can be an early alarm system. So just when we look at these pieces holistically, everything is sort of trending up. One of the things that we are less interested in now than in the early days of the pandemic is our percent positivity. So if you'll remember, in the early days of the pandemic, everyone talked about percent positivity as though that was the only metric that mattered. And that's because we didn't have enough testing out there. We now have testing not only widely available, but we have testing that isn't reported. So the percent positivity is less helpful because it really depends on the types of folks who are testing. So when it goes up, it could be that the people who are getting PCR tests, the type of tests we get reported to us, they are folks who've already tested positive at home, and now they're in the hospital because they're not feeling well, and they have, complications from COVID. So percent positivity is the one metric that is less helpful now than it was early on. But otherwise, we try to take that data and put it together and come up with a holistic picture of where we are and where we're going.
Wonderful, thank you. We do have one additional question in the chat. Paxlovid seems to have rebound symptoms. Have you seen rebound symptoms requiring hospitalization?
So I personally have not, but I will tell you that for Paxlovid, as well as for any medication, we're really talking about risks versus benefits. And so Paxlovid, I think for a while, it became something that everyone perhaps wanted who had COVID. And it may not be the right option for everyone. We're really trying to target this towards those who are at risk for severe outcomes. And so for folks who are young and healthy and fully vaccinated and boosted, Paxlovid may not be the appropriate choice for them. We're really talking about folks who are older, who have other comorbidities, and who are at higher risk for having some of those negative consequences. There's a question in the chat about departing from CDC's isolation guidance and doing a rapid antigen test to return to work. One of the issues with that is that, of course, we know that people can test positive for some time afterwards. So PCR, it's more problematic, of course, people testing positive for longer after they have an infection. But even for antigen, it's possible to have intermittent shedding. It's possible to pick up on virus that is no longer really high risk of causing transmission, something that's not really viable in terms of causing widespread transmission. And so that is why the CDC went to 5 days and at home, 5 days with a mask. Of course, we do recommend if you are feeling unwell still, if you have symptoms, that then you would really start thinking about extending or retesting if your symptoms come back. But I think it's difficult, especially now in the pandemic, to ask anyone to do more. People are ready to move on from COVID. A lot of people want to just not think about COVID again, which is unfortunate because we are starting to head back into a higher risk time of the year. So asking anyone to do more right now, I think is problematic when no one wants to do anything for COVID.
Thank you. And then we do have one additional question. Is there any data that shows Paxlovid prevents long COVID or long-term impacts of COVID on the body systems?
A lot of the data on long COVID is still emerging. Still it feels like this is year 10 into the pandemic. I sometimes forget that this is just, year 2.5 into the pandemic, because COVID time is, of course, different than real time. But the virus just simply has not been around enough for us to really understand what are the long-term consequences, what are the 5-year, the 10-year consequences of COVID. And the studies that are happening right now, how they're defining long COVID is also, that's something that needs to be worked out and defined. Long COVID can be defined based on subjective symptoms, or it can be defined based on things that are measurable. So even how we define long COVID, I think, is something that is being worked out, and we need more consistency across the board before we can really look at the data and interpret the data in a more holistic way. But I would say that the way that Paxlovid works so rapidly to suppress viral replication, it is likely that some of those long-term consequences, we know that it prevents severe, or it reduces the risk of severe COVID, but it's likely that some of those long-term consequences could also be blunted. But again, we'll know more, I think, in a few years' time.
Wonderful. Thank you very much. Any additional questions before we move on to the next portion of the presentation this afternoon?
Thanks, everyone.
All right. Well, thank you so much, Dr. Bagdasarian. We really appreciate you sharing your expertise and sharing it with our rural Michigan providers. And just, you know, thank you for all the work that you do each day for Michiganders. Have a wonderful day. Thank you. So with that, we will go ahead and turn it over to our next portion of the presentation. We'll turn it over to Nick Torney, who will kick off our 2 rural best practices on the test to treat model. I will pull those slides up now, Nick.
Okay, thanks, Crystal. And thanks everybody for allowing me to join this afternoon. So my name is Nick Torney. I'm an infectious disease pharmacist at Munson Medical Center. And you can go to the next slide. So when Paxlovid first came out, we at Munson Healthcare wanted to understand how we could potentially implement this at our emergency departments across our health system. And as we all know, pharmacists are really essential in the dispensing of this medication, and due to the drug interaction management, evaluation of contraindications like kidney and liver function, and dose reduction when renal impairment is found. So the question really became, how can we implement a Paxlovid dispensing direct from our emergency departments across Munson Healthcare without a 24/7 ED pharmacist coverage at each of those facilities? You can go to the next slide, please. And so in looking at our health system, it's a rural health system in northern Michigan. Traverse City has the largest hospital of the health system. That's Munson Medical Center, is a level 2 trauma center with 440 beds. And we're fortunate enough to have an ED pharmacist on site 24/7. All other facilities really have less than 80 beds, many just 20 to 30 beds, with pharmacists covering only during the daytime and many times not even on the weekends. Next slide, please. So on April 6th, we went live with Paxlovid prescribing from the Munson Medical Center ED. This decision was made because, you know, we're obviously able to test patients in the ED, and we have 24/7 ED pharmacist coverage at Munson Medical Center. So that made it an easy decision to start a 1-week pilot there. This went really well. Prescribers would lean on our pharmacists and collaborate to dispense Paxlovid directly from the emergency department to those patients. And then we moved that out to other hospitals as located on this map here. In a stepwise function, it didn't go all at once, but now most of these hospitals, if not all of them, are prescribing Paxlovid from their emergency departments. When the facility has a pharmacist on site, they use that pharmacist to check for contraindications and renal dosing. And when the pharmacist is not on site at those facilities, an ED provider would call the Munson Medical Center ED pharmacist, and with that conversation, review medications and other contraindications, and that ED pharmacist would provide that consult, and they would dispense then, if applicable and appropriate, they would dispense Paxlovid from their emergency department. We have the normal dose Paxlovid and also the renal dose Paxlovid located in the emergency department automated dispensing cabinet. So nurses can, once that's verified, nurses can pull that medication, the full course, right from the dispensing cabinet and dispense that to the patient. Next slide, please. So we developed a 1-page document, and this isn't just for our emergency department team, but also for outpatients. And nothing on this document is really new or novel. It's just taking all the information and kind of putting it into a 4-step process. So I won't go through all these steps in detail, but it gives you an idea for what it takes to safely prescribe Paxlovid and where the pharmacist really steps in to assist in that process at our health system. So really for checking drug interactions and consulting on what to do with other medications while taking Paxlovid. So whether it's statins or other medications that maybe can just be held versus more severe contraindications like some of our immunosuppressive agents like tacrolimus, having a pharmacist there to say, yes, this is safe, or no, maybe this patient is not a candidate. And then also reviewing renal function to determine the appropriate dosing, making sure that that is a relatively recent serum creatinine that we're evaluating that eGFR for, and then prescribing. We can do that again directly from our emergency department, and we also have resources for pharmacies across northern Michigan that have Paxlovid, which by now most of them already do. Next slide, please. So this is just a summary and a size 4 font of our outpatient treatment guideline, and it tries to include most, if not all, of the considerations for each of these agents. We try to utilize Paxlovid as much as possible in those high-risk patients, and we do have access to a very small amount of bebtelovimab, just like all other health systems out there, I'm sure. So we have a lot more strict criteria for that. And molnupiravir, as we know, is an alternative when either of those two agents are not able to be used. Next slide, please. And just to round this out, I just wanted to share our utilization data from when we went live with this until just a few weeks ago. So you can see we've used about 150 courses, or have dispensed, 150 courses of Paxlovid at our emergency departments across Munson Healthcare. This is just Cerner sites. We do have a couple other non-Cerner sites that I wasn't able to get data for. But so probably between 150 and 200 courses since this time frame at a Munson Healthcare Emergency Department, which we're pretty happy with. And in talking to our emergency department pharmacists at Munson Medical Center, they have commented that this process has actually gone quite smoothly, a lot smoother than what they anticipated. But they've really, we've leaned on them quite heavily to be that resource for our health system, and I want to give them kudos and a shout out for that, and incorporating this into their normal workflow. If you don't have that ED pharmacist 24/7, it's definitely a lot more difficult, but not impossible to do this. And happy to discuss that further if anyone wants to discuss that, when we have time available after this presentation. So with that, I'll end, and we can take questions now or after.
Thank you very, very much. We do have one question. How did you manage to do this in your ERs with nursing shortages, or is the pharmacist managing the meds?
So it's really not much of a lift, an extra lift for nursing. And the pharmacist can, especially in our emergency department, pull the medications from Pyxis as well. But it's really, I guess I haven't heard any issues with nursing shortages at our health system that haven't allowed us to do this. It's actually much easier to do this than it is to give bebtelovimab in the emergency department, for instance. So
thank you. And then what do you do if you do not have labs GFR available?
if it's within 6 months, we will just base the dosing on the patient's current serum creatinine within the last 6 months or a year, I guess, depending on the patient. But we would get we would recommend getting an EGFR for patients, or I'm sorry, a serum creatinine for patients when in doubt, especially for elderly patients or for patients that were concerned about them having an EGFR less than 60. So for most patients, they would be getting serum creatinines in the emergency department because we are able to do that there.
Perfect. And I think we'll do one more prior to moving on to Amanda, just to ensure that we have time for her presentation, and then we will have time for a full question and answer session at the end. So how about the infection control of the patients in the ER that need this treatment? So alluding to the exposure, did you have an isolation area set up?
So yeah, we have specific patient rooms that are designed for patients with COVID-19. And so we don't, any patient with COVID-19 gets handled the same way, whether they're getting Paxlovid or whether they're getting no treatment because they don't meet criteria. Let's say they're low risk, something like that. So it's the same infection control standards that we use for patients with COVID-19. We apply to that for patients getting Paxlovid as well.
Thank you very much, Dr. Torney. So we will go ahead and move on to our next rural best practice for the Test to Treat program. Dr. Torney will stay on though, so we will have a question and answer session after Amanda Michelas is finished presenting. So please stay on. And if you do have any questions, feel free to place them in the chat, or we will have some time to unmute at the end of the program. So with that, I would like to turn it over to Michelas with the Marshfield Clinic Health System. Welcome, Amanda.
Thank you, Crystal. It's an honor to be here today to talk with you all about a really important opportunity and option for clinics and rural systems to get medication out to patients in need. So we can advance the slide. And I'm here today representing two different arenas. The first is the National Association of Rural Health Clinics. And this being a rural Test to Treat conversation, I just wanted to throw this out there. So there's 5,000 RHCs, and using the reaction button on the bottom of your screen, just send a little reaction. Let me know if you're joining from a rural health clinic out there in Michigan. 1 in 5 patients in the United States receives care in a rural setting in an RHC. So in rural, we can really make an impact doing this. And I just wanted to share our story. So I'll be sharing the story of Marshfield Medical Center Dickinson, and we're located up in Iron Mountain, Michigan, in the UP. So again, if any of you are UPers, I'm excited to be here speaking with you. We are a 49-bed sole community hospital, and we have 7 provider-based RHCs that service our community. Our primary service area is about 25,000 people, and our secondary pulls 75,000. The Marshfield Clinic Health System is home to 11 hospitals. We're the first of which in Michigan, and we deliver care at 60 sites throughout Michigan and Wisconsin. So we're able to impact quite a bit. So when it came to our Test to Treat program, and this opportunity came out for Paxlovid, we really leaned on our COVID steering committee as a foundation. So like many of you, when COVID started, we opened an emergency operations center. And our chief nursing officer of our hospital chaired a COVID steering committee. And what was unique about our COVID steering committee was that we really had partners in the Dickinson Iron Health Department and our community businesses that joined in, and then our hospital and providers. So led by our CNO and a physician, Dr. Toby Carlson, we used this group as the foundation to figure out how we were going to start the Test to Treat program. We met almost daily to start, and then got into a frequency after which, in which we could meet the needs of whatever was going on in the pandemic. And what we did for Test to Treat is when COVID vaccines came out, when additional tests came up, and when Paxlovid came out, we noticed that our health system and clinics were inundated with calls about questions. Could they reach us? Could they get the medication? They were coming to lab, switchboard, clinics, the floor, everywhere. So what we did under the umbrella of that COVID steering committee was to create a hotline, one number that patients could call to get COVID-19 information about their eligibility for Paxlovid or testing. And we used some grant funding to place a coordinator, Daniela, who was able to be on that line use the MDHHS guidelines, and help those patients in real time. So they were getting information out to them as soon as we could. We partnered with our physicians and our pharmacy team here on site to get some protocols in place so that Daniela could speak with those patients, get them to come in and get tested, and then if necessary, get the right antiviral or Paxlovid out to them. One of the things that we noticed was our community wasn't able to get to us all the time. So we offered delivery of these medications through our pharmacy right to our patients in our communities if they needed that. We knew that this was something new, and to get this out, we needed to take any steps that we might need for that. So really just a community-based approach, using that coordinator to be that spearhead to help out and getting the information out to the folks that need it. So I know that Nick shared some of Munson's doses. Our hospital here has prescribed 42 doses, some of which coming into our pharmacy here, some of which going to other pharmacies in towns around us. But what we noticed when we started this Test to Treat program is that many of the health systems around us were not doing this and did not have access to it. So we were pulling people from 2 and 3 hour radiuses into our health system. Nick, some of the care that we provided was in our EDs. Some of this through the coordinator was able to be done through the patient's primary care offices and their rural health clinics as well. So I guess there's really no right way to do this or no right care continuum to do it in. It really can be done if you're a health system, if you're a hospital, if you're a clinic. You can stand up ways with different resources in which to get this out to patients. So we can go to the next slide. I think one of the things that was really important in ensuring that this was successful for us was just advancing the health equity and understanding in the community. And you can start a Test to Treat program, but if the community business partners and the community members don't know how to access it or what to do, it won't be successful. So really a multimodality approach was one of the things that helped us out. We had our staff members make videos. We had physicians, nurses make videos and post them on different social media outlets to get out to different generations of our patients. We had ads on the radio, our website, just letting people know, hey, this drug is out there, it's new, this is how you can access it. If you're concerned that you have COVID, this is who you can call and we'll help you. We knew that we would be a trusted leader in our community, and we wanted to be there for our patients in any way that we could to do that. Our primary population that we serve here at this hospital is primarily geriatric. So just finding ways to reach out to that high-risk population and that they would hear us was something that we put great focus on. And we're proud to say that the Dickinson County actually led the vaccine rate for those getting vaccinated in patients over the age of 75 at a portion during the pandemic. So getting out there and reaching out to the community through business partners, through a COVID steering committee, through a coordinator, anything you need to do to get patients into access really helped for us, and we think it might help for you too. And I'm going to leave you with just a story. So the Test to Treat program, it's certainly something new, and it's something that can be built in different ways in different areas. But our why was we were reaching out to one of our patients. She was an 82-year-old female who doctored at one of our clinics here in town. We were reaching out to her as a high-risk geriatric population patient to help her to get vaccinated early in the pandemic. And when one of our team members called her, she said, and we let her know, hey, you're eligible for the vaccine. We can get it out to you. You can come in and get it. And she said, you know what? I feel like I just won the lottery. I've been home. I don't have family around, and I've gotten word that a lot of my friends have contracted the virus and gotten sick, and some of which have passed away. I feel like what your clinic is doing just gave me my freedom back. So it's easy when you hear about these programs to say, well, it's hard to stand up, or it might not work here, or we don't have the resources. But what we'd like to share is our why is that 82-year-old female who was able to access our Test to Treat program, was able to get vaccinated with us. We're rural. We don't have all the resources of some urban systems, but we were able to make a difference in her life. And we just wanted to share that story and let you know, use process improvement. If something doesn't work, just change it. And we believe that you can start Test to Treat programs too. There's a couple of resources on the next slide as well that you can use, one of which from MDHHS, which I'm sure you all go to, another which from NARHC that has some really neat information if you're a rural health clinic, how to access some of the free test kits or the Paxlovid medication. So I just wanted to throw that out there, and happy to take any questions on how we set our program up.
Wonderful. Thank you so much, Amanda. So thank you very much to both Dr. Torney and Ms. Sheelist, not only for the presentation today, which was great by both of you, but just for everything you're doing for your rural communities. It's appreciated. So now we will open it up to a question and answer session. So should you have any questions, feel free to place them in the chat box. Feel free to raise your hand using the raise hand function, or just simply unmute yourself. Wow, you guys must have done such a remarkable job that we do not have any questions because you were so comprehensive. Actually, we're having one come through, so wonderful. Let's read the question in the chat. Oh, this is interesting. So will your steering committee persist and be applied to other health challenges besides COVID? I like that question.
Thomas, thank you for the question. It was stood up as a COVID steering committee, but our organization actually experienced a cyber attack shortly thereafter the pandemic started. So we were able to utilize that same group of people, including our community peers, to help with that. So I guess we multifunctioned it. It wasn't set up to do that, but we did.
Wonderful. And it looks like Rhonda Warren has a question as well. Rhonda?
Hi, yes, I'm sorry I can't find the first speaker's name, and so I apologize. But you were using an epidemiological term that I was trying to look up, and I thought maybe I wasn't hearing correctly. It was the term waste management, but maybe it's weight management. Could you clarify, please?
And I believe,
Hi,
oh, go ahead, Linda. Thank you.
Yeah, hi, this is Linda Scott. I think Dr. Bagdasarian was talking about wastewater surveillance, and that is a type of surveillance that is underway in certain communities where the wastewater from a community is tested for COVID and other things, and it can be used as a precursor to increasing trends in a community. So kind of one component of a surveillance system that provides additional information when you're looking at the big picture of how something is impacting the community. And there actually is information on MDHHS's COVID site on wastewater surveillance.
Thank you. I appreciate that because I did look up the term and I just wasn't sure before I proceeded further. So thank you so much.
Our pleasure. Thank you for the question.
Wonderful. Any additional questions? All right. Well, again, thank you to all of our presenters. Oh, Linda, you have a question. Hi, Linda.
Old-fashioned raise your hand. Teresa, did you want to talk about if any of our colleagues that are on this call were interested in getting more information or wanted to become a test to treat site? How they could get us information or we could get them additional information?
Yes, so if you are interested in becoming a test to treat site, and I will repost the link again before before we are done here today, on our Michigan.gov coronavirus website, under the COVID-19 therapeutics information page for healthcare providers, there is a link for test to treat folks that are interested in test to treat. You can fill out the information it's a little survey. It asks you for some information, and then we will reach out to you to get you up and running in a test to treat situation. So we're looking at, are you have the ability to test? Are you, you have some type of healthcare provider that can interact with that person, and then a pharmacy either on site or right near you to make that work. So if you are interested, you can go to our therapeutics website and answer those questions, and we will reach out to you to get you onboarded for test to treat.
Wonderful. Any other comments from our state of Michigan representatives on the line? All right, well, with that and not hearing any other questions, I will go ahead and close out the presentation for today. So first of all, thank you for all of you for attending. Should you need a certificate of attendance, please just indicate that in the chat with your email. That would be very appreciated. We are working to get the slides posted on the MDHHS website, which Teresa linked in the chat, and the Michigan Center for Rural Health website. The presentation was recorded and will be posted to both of those modalities as well. So thank you to all of our presenters today for sharing your information and your expertise. And finally, just a thank you to all of you on the line for all that you do for rural Michiganders each and every day. Have a wonderful day and thank you for attending.